Many of your nulliparous moms will come into the hospital during early labor simply because they're not sure what to do and when the time is right for them to need to come in. Your multiparous moms will often stay home during early labor where they can progress to active labor more comfortably. They're in their own environment, they can move around, they can, drink some clear liquids if they want to. When a woman comes into the hospital and is assessed, if she's not at least 3 centimeters, then they may send her out to walk around a little bit. They may send her to the mall or just to a park, or if she's close enough, send her back home until her contractions become a little bit more stronger, more regular, and they can start seeing evidence of cervical change. According to the EMTALA rule, true labor is considered an emergency, and regardless of a person's history, their ability to pay for services rendered, the presence or absence of medical records, prenatal records, pretty much anything else, agencies do have to care for a laboring female. Therefore, when any pregnant patient presents for triage or assessment with complaints of labor, she has to be accepted, put in a bed, assessed, and cared for as if she were actually in labor until a qualified provider determines that she's not. Assessment of the laboring patient begins at admission and continues throughout labor and delivery at frequent intervals. Now, many of you have heard me say, what is frequent? A lot of times the documentation of the assessments will be done at specified intervals based on hospital policies or policies and recommendations of governing organizations. Your first assessment is done to see if she's in actual labor. She will be placed on the electronic fetal monitor to determine duration, frequency of her contractions. In labor, contraction patterns become organized and are longer, stronger, and closer together. The general rule of thumb for labor is a contraction pattern of 5-1-1. Contractions every 5 minutes, lasting for at least a minute, and has been doing this for at least 1 hour. If she is indeed in true labor, the contractions will be causing cervical dilation and effacement. Cervical change is one of the definitive criteria that determines a woman is in true labor. Another assessment performed is to determine the position of the fetus. The vaginal exam will kind of estimate how much cervical change has been affected with the contractions, as well as what the presenting part may be and where it lies. Remember, from what we've talked about in the past, engagement in station is identified in terms of -5 to +5, depending on the presenting part in relation to the ischial spines of the pelvis. If she's determined to be in labor, she'll be admitted as an inpatient into either an LDR, which is a labor, delivery, and recovery room, or an LDRP, which is labor, delivery, recovery, and postpartum. In an LDRP, the patient is admitted to that room and she doesn't leave that room until it's time for her to discharge. Well, we all know assessment is one of the first steps in our nursing process, right? So what you're going to do is review the prenatal records to help look for and identify concerns. What's her blood type? Is she Rh negative or not? Has she had any previous infections, sexually transmitted infections, gonorrhea, chlamydia? Has she had BV in the pregnancy? Or is her GBS, her group B strep status, positive? What's her rubella status? And any previous pregnancy complications such as fetal macrosomia, large babies, or has she ever had a hemorrhage event? Look to see if she ever received a blood transfusion for anything. Look at her vital signs, especially the blood pressure, for any trends that could indicate a concern for preeclampsia. Does her history include smoking, drinking, drug use of any kind? Look at the ultrasound reports to be sure there are no issues such as a placenta previa or a growth restriction. And check to see that you keep all of her visits as scheduled. Did she receive adequate prenatal care just based on being seen by the provider in a timely manner? It's also very important to know the age of your patient in order to meet her specific needs in an age-appropriate manner. Handling a 17-year-old patient is going to be a lot different than a 27 or a 30-year-old patient. During the interview, you're going to determine what her chief complaint is. Ask her, what brought you into us today? If she complains of contractions, determine, what she is gauging the frequency, duration, and intensity of these contractions, and ask her, has she ruptured or has she noticed any bloody show? Ask if she's taking any over-the-counter medicines and what the reason she's taking those may be. And just do a quick, review of systems to check for things to make sure she's not having nausea, vomiting, dizziness, headaches, visual changes, anything like that. It's important to screen for any history of abuse, and I mean any kind of abuse, emotional, physical, verbal, sexual, anything. To do this sensitive type of assessment, you're going to need to interview her in private. You're going to need to be non-judgmental and use very clear terms whenever you're talking to her. Observe her nonverbal body behavior when she's answering these questions. If you look on page 343 in box 12.2, you can see a psychosocial assessment guide to kind of help you out. Many women deal with the stress of labor with preparations such as birth plans or techniques that they've learned from going to prepared childbirth classes. So you want to make sure that you determine your patient's wishes for either of these things. If she has a birth plan, bring it out and go over it with her. Talk about desires for pictures or videos, making sure that you can speak to hospital policy about any pictorial documentation of delivery. As always, cultural competence is critical when we're caring for these women. You will need to respect her wishes in regards to labor and birth as long as there's not a conflict with providing safe care. If she wishes the room to be warm, then warm it up. If she doesn't want a male provider, do what you can to honor this. Sometimes the best thing that you can do is say your husband will be allowed to stay in the room with you at all times when another male is in the room. You do as much as you can to protect and maintain her cultural dignity. If there's a language barrier, the hospital is required to provide interpretive services in some form, whether it be a hospital-validated interpreter, a language line, or pictures and words that are listed out in her native tongue. Having the EFM attached will graph out your fetal heart patterns and your contraction patterns. However, you do not need the monitor to tell you that she is contracting. First, you can see her abdomen change with the force of a contraction. As you see in the picture here, the abdomen will actually rise as the uterus bunches in a contraction. You will also be able to feel the uterus firm up and can measure the intensity of the contraction with palpation. If the fundus feels like the tip of your nose and is easy to indent, we chart mild intensity by palpation. If the uterus is more difficult to indent and feels like your chin, we call that moderate. And if the uterus is firm and feels like your forehead, we call that strong intensity. Once the contraction is complete and the uterus is at rest, you palpate to confirm that the uterus returns to a soft resting tone. Remember, when you are using the monitor to track contractions, you look at frequency as the beginning of one contraction to the beginning of the next, and duration is the beginning of the contraction to the end of the contraction. Here you see examples of a laboring cervix and one that is not in labor. Whether or not gloves need to be sterile for cervical checks is facility specific. However, if she has experienced rupture of membranes, then you will definitely need to wear sterile gloves. Be sure you explain to her what you are going to be doing, and remember that this may be very uncomfortable and embarrassing for some women. In picture A, the cervix is thick and closed and the fetus is high in the abdomen. In B, you see a cervix that is partially dilated and effaced, and the provider is able to stroke the fetal head to identify suture lines and fontanelles and kind of figure an orientation of the fetus. If you will look on page 347 in your text, you will see steps of Leopold's maneuvers. When done on a pregnant patient, you should be able to determine fetal lie, presentation, position, and engagement if the fetus has dropped into the pelvis. Leopold's maneuvers is also a helpful process in determining the best placement for the fetal monitoring ultrasound in order to best be able to track your fetal heart rate patterns. In considering labs and diagnostics for your assessment in first stage, you definitely want to check the urine, at least for glucose and protein. And if you're concerned by the way it looks, if it's cloudy or bloodied or has a foul smell, you can do a full urinalysis to rule out infection. She will need a CBC, or more specifically an H&H. You want to make sure she's not anemic and she doesn't have a pre-existing infection that could indicate labor. She's going to have a transient increase in her white cell from the stress of being in labor and having the baby. We want to make sure nothing is elevated before that. Platelets are necessary before an epidural can be placed to minimize possibility of bleeding in the epidural space and to check for other clotting issues. We certainly don't want to have an OB hemorrhage on our hands. All women are type and screened, and if there is any risk of excess bleeding, previous hemorrhage event or anything, she may even be type and crossed. If her Group B strep is not listed in the medical record, there may be a rapid GBS screening done on her. If there's a question regarding rupture of membranes, is she intact, is she not, I can't tell, the nurse can test what discharge is there with nitrazine. It's either going to be a nitrazine paper or they actually have swabs called amni swabs. If the pH of the discharge is very alkaline, it is likely to be an amniotic fluid. However, if the nitrazine comes in contact with blood, with KY, with urine, or any alkaline fluid, the nitrazine paper will give you a false positive result. The only definitive rupture of membrane test is a FERM test, which is performed by the OB provider. For them to do this, a sample of the suspected fluid is collected using a sterile cotton-tipped swab. The swab is then run over a dry microscope slide, and the slide is allowed to air dry. And you don't put a cover slip over it, it's just open to air. You'll look at the slide under the microscope, and if it is amniotic fluid, it's going to have a crystal-like, fern-like pattern, almost like, if you can imagine frozen frosted windows in the winter time, how they kind of have that lacy crystal look to them. So if she did indeed rupture, you're going to remember the acronym COAT. C is for color, O is for odor, A is for the amount, and T is for the time. So if she ruptured out of your presence, asking these questions is going to give you an indication if there's any concern for infection or fetal distress or anything like that, which we'll talk about a little bit later. Alright, so in first labor, when we're going through dilation and effacement and we're having to get those contractions longer, stronger, closer together, what are some things that we need to worry about? Well, if she is having contractions that last longer than 90 seconds or are coming closer than every 2 minutes, then we are having the potential for tachysystole, which tachysystole is more than 5 contractions in 10 minutes, averaged over a 30-minute window. Not a good thing. And if that contraction is going too long, then it's not going to have an adequate resting time. So if you have a shortened resting time that's less than 30 seconds, or you have an increase in your resting tone, that's another potential complication. If when she ruptures, either you or she notice meconium-stained amniotic fluid, which means it's going to have anywhere from a pale greenish tint to it can actually be like pea green, thick and sludgy. If it's got meconium, that's a sign of fetal distress. If the fluid is bloody or has a foul smell, that could indicate abruption or infection. If mom starts spiking a temp, there may be a developing infection, especially if she's been ruptured for a long period of time. Or if you see vaginal bleeding, that is not the, pretty much anticipated bloody show. Bloody show is typically going to be a little bit thicker, and it's going to be a mucoid, and it may even be a brownish reddish color. Vaginal bleeding, bright red blood, is a sign of complication. It's important to keep the mom calm and comfortable, and part of that is keeping her clean, just being clean. You got to remember she's going to have periods of sweating and then chills, and she's going to have blood, amniotic fluid, other discharge pooling up underneath her. So you want to change out the chucks pad or the under pad frequently. You might consider using a folded up towel maybe between her legs to catch the fluids, and it'll help keep her dry. Keep dry gowns in the room, and offer to help her change if she gets one wet with sweating or other body fluids. In many places, women are kept NPO when they're in active labor, except for maybe ice chips, and early on she may get some clear liquids. You have to remember there's always a possibility of something happen during the labor progression that is going to necessitate a cesarean birth. So you don't want her to have solids in her stomach for fear of aspiration. She will be able to maintain hydration with her IV fluids. Commonly the fluids used are normal saline or Ringers. The body will go through a natural cleanse on many instances, and the woman can be embarrassed with urine or stool incontinence. If she gets an epidural, the provider will order either an indwelling catheter or a straight cath to keep her bladder emptied because she can't feel the urge to void anymore. And remember from previous talks, we said the bladder needs to be emptied at least every hour to allow the fetal head to descend and the bladder's not blocking the way. During pushing, it's not uncommon for a stool to pass as the fetus descends and delivers. And because of these events, she may experience body image issues and a feeling of loss of control. If she does not have an epidural or Pitocin, then encourage her to move around, ambulate in the hallway, rock in a rocking chair, or even, slow dance with her support person. Anything that's going to change her position, which will also help the fetus rotate and descend. It's recommended that the laboring woman change her position about every 20 to 30 minutes, and as I said, her bladder needs to be emptied every hour to help maximize rotation and descent of the fetus. Positions for labor include standing, squatting, side lying, and hands and knees for your basic positions. Alright, so in first stage, as a nurse, you're going to be there to keep the mom informed. Let her know what's going on, how she's progressing. Make sure that you support her in what she's doing, in the efforts that she's making. You will be monitoring her continuously, okay, going in and assessing that continual monitoring and documenting as per facility protocols. You may need to run interference for the mom with family and visitors. You're going to help manage pain with either ordered medications or the therapeutic interventions, the guided imagery, the relaxation techniques, the massage. You're going to coach her through the labor and the birth process. Now the partner is going to provide emotional support and help with comfort measures. Maybe give her some ice chips, do lip balm because she's going to be breathing through her mouth more. Doulas, they've been shown to decrease the amount of pharmacologic interventions that a woman has to use. There have been less assisted or operational vag delivery, so we're not needing to use forceps or suctions as much. And overall, maternal satisfaction with the labor and delivery process has been increased when doulas have been in place. When you're looking at siblings for the newborn, you need to factor what their age is into just how much they're going to be allowed to see and do. Obviously, the younger ones, it can be a frightening experience for them. The older ones, it may be an embarrassing experience for them. So you need to look at where the sibling is, age and development-wise. It may be necessary to prepare the siblings for what they're going to see. You can use pictures, stories, explanations, videos. Take them on a tour of the birthing suite and just kind of explain what the tools are, just to kind of give them a heads up and let them be a little bit better prepared. Now, looking at emergencies, if you go to page 361 in your textbook, you'll see what measures are taken for emergency situations in labor. For most OB emergencies, the nurse is going to change mom's position, give a fluid bolus, and manage the medications. She may decrease the pit if the woman's contracting too much. Give it about 10 minutes. If we don't slow down, then she'll turn the pit off. If you are going to give oxygen, you're going to make sure you give it by a non-rebreather face mask. That's a very important piece to remember, non-rebreather. Notifying the OB provider is obviously very necessary. However, another nurse may be notifying the provider while you are doing the first things we talked about, or you will do the things that you talked about, get the result, and then you'll call the provider and tell them what's going on. If there is a cord prolapse, then you're going to put on sterile gloves. You're going to insert fingers into the vagina, and you're going to lift the presenting part, usually the head, up off of the prolapse cord, and you're going to have to stay with your hand in, holding the head up off that cord until the patient is taken to the OR for a cesarean delivery. That means you're going to ride in the bed with her, you'll move to the OR table with her, you're going to stay on the OR table with her, they will prep and drape around you, and you're going to keep your hand in place, holding that head up until you actually feel the fetus being lifted out by the delivering provider in the C-section. Alright, second stage is the entire time that it takes to go from being complete, i.e. 100% effaced, 10 centimeters dilated, to delivery of the fetus. For first-time moms, stage 2 can last as long as 3 hours if she has an epidural, 2 hours if she does not, but the median length of stage 2 on your first-time moms is about 50 minutes. For your multiparous mom, second stage can last up to 2 hours with regional anesthesia, epidurals, or 1 hour without, and the median time for second stage on multiparous moms is 30 minutes. If durations of second stage go beyond these time frames, labor is considered to be prolonged. As with stage 1, stage 2 has 3 phases: the latent, the active, and transition. In the latent phase, we let her do something called laboring down. In laboring down, we let the primary powers, those involuntary uterine contractions, push the fetus down the birth canal so that when mom actually has to start pushing and we get those secondary powers coming into place, then she doesn't have to push so long and so hard because there's not as much ground for her to cover and to have to push through. When the presenting part hits the pelvic floor, stretch receptors are triggered, and a release of endogenous oxytocin causes mom to experience the urge to bear down. You may remember this from class. We say this is known as Ferguson's reflex. Now, if she has an epidural, Ferguson's reflex may not be felt as strongly. It is important for the patient to try to focus, try to listen to what her body's telling her, and if and when she does feel an urge to push, then push, such as with transition. In the final phase of stage 2, the pushing is most effective and the primary and secondary powers work together to deliver the fetus. As with labor, there are different positions that can be used for delivery, such as squatting, side lying, hands and knees, or the common semi-recumbent. During pushing, the woman may experience a myriad of emotions and physical response, such as crying, yelling, laughing, swearing, chills, shaking, sweating, and even nausea and vomiting. When it's time for her to push, the nurse should help guide her through pushing. Okay? A woman should use open glottis pushing as opposed to closed glottis. Closed glottis is taking a deep breath, holding it in, and bearing down for a count of 10. Okay, and typically they do that 3 times during each contraction. But closed glottis pushing results in a Valsalva effect and interrupts cardiac output and circulation. That's not good for mom or for the baby. Assessment is continuous in second stage, with the EFM continuously monitoring the fetus and the blood pressure cuff set to check mom's blood pressure about every 5 minutes. And we're getting heart rate on mom. The nurse never leaves the room, and really she shouldn't leave the perineum until the delivery provider presents for the birth and to catch the baby. Now, each facility will have specific policies and protocols in place for how a patient in second stage is attended and monitored. In preparation for the delivery, a table will be set up in sterile fashion and will be placed within the provider's reach so that the provider can stand or sit at the perineum and be able to get the tools that they need. The table is going to have sterile drapes. It'll have sterile instruments and the necessary supplies for procedures such as cord blood donation, cord blood samples, cord blood gases, the clamp for the umbilical cord, scissors to cut the umbilical cord, instruments, needle drivers if they need to do a repair. While many facilities have gone to the labor, delivery, recovery in one room concept, so the LDR, there are still places where the patient may be transferred to a different room altogether when it's time to deliver. And that may be some of your smaller hospitals or rural facilities where, they just don't have really a maternity suite. They just have all patient rooms. Mom may labor in a room, but then she'll go into like an OR type of room to deliver the baby. Now, we talked about the 7 cardinal movements that the fetus must go through in order to be delivered. Engagement and descent, flexion, internal rotation, extension, external rotation of restitution, and then external rotation complete. The Ritgen maneuver is the delivery of the child's head by pressure on the perineum while controlling the speed of delivery by pressure with the other hand on the fetal head. The provider will control the birth of the head, making certain delivery isn't explosive through the introitus because that can result in tears and lacerations. The provider will have the mom maybe even hold pushing for a few seconds while they make sure to check and see if there's not a cord wrapped around the neck, which is also known as a nuchal cord. The provider will then gently direct the head down, release an anterior shoulder, and then back up to release posterior shoulder. And once the shoulders are out, it pretty much just slips right on out, kind of like in a swoosh motion. Again, the provider will be checking, making sure there's not a cord wrapped around the body this time. And once the baby is out, immediate drying and stimulating is performed by a second nurse. APGAR assessments and scoring are completed at 1 minute and 5 minutes. And if the APGAR is greater than or equal to 7, everything's considered normal. If mom and baby are stable, the baby can be placed skin to skin, so baby's chest on mom's chest in the kangaroo position for extrauterine transition and hopefully the first breastfeeding. Injuries of delivery include lacerations or episiotomies. The depth through which a perineal tear or a laceration occurs will determine the degree of the laceration. So in a first degree lac, the damage extends through skin and tissues, but it's superficial to the muscle layer. In your second degree, that injury extends through the muscles of the perineal body. Your third degree is a little bit more intense, and it continues a tear all the way through the anal sphincter. And bless the woman with a fourth degree, because this tear involves all the way through into the anterior anal wall. So you can imagine that women who experience third and fourth degree lacerations have a pretty extensive perineal repair and a much longer and more challenging and complicated postpartum recovery. Very, very painful. The other soft tissue lacerations that can occur, cervical, upper vaginal wall, can be resultant of a precipitous or rapid birth, and they are seen in conjunction with perineal lacerations. It's really important to remember any laceration poses a risk potential for varying degrees of hemorrhage if you don't identify the source of the laceration and the injury and manage it appropriately. Episiotomies are performed if the delivering provider believes that a wider space or opening is necessary to facilitate an atraumatic birth. However, there's been an increased incidence of third and fourth degree lacerations seen when episiotomies were performed by providers. So because of this and just the overall healing, routine episiotomy use has really declined since, kind of like somewhere in the early 1990s. And the new practice is to support the perineum as much as possible during the labor and the birth process. Let the tissues tear naturally instead of cutting them, therefore lessening the potential of a worse injury. Now, third stage is simply the period of time where the placenta delivers. It can take up to about 30 minutes, but generally a placenta is going to deliver 5, 10, 15 minutes tops. Once the fetus is out, the uterus will have a sudden decrease in the overall volume and shape, and that's going to initiate the placental detachment. The uterus is going to continue to have contractions, not to the same intensity of labor, but the contractions that persist will help expel the placenta. As the placenta moves into the lower uterine segment, you're going to see a shape change of the uterus. It's going to go from a discoid shape to a globular shape. So remember that. The uterus changes shape from discoid to globular. You're going to see a gush of dark blood coming from the introitus, because now the placenta is detached, so you've got that raw surface opening. So you're going to have a gush of blood, and the umbilical cord is going to lengthen, because what you've got to imagine is, where it was attached up higher in the uterus, well, now that the placenta is dropping down, obviously you're going to have more cord coming out, so the cord is going to lengthen. Finally, there's going to be a vaginal fullness. Because the placenta is coming down and it's just sitting right there in the distal vagina. You can probably see it the same way you'd see the fetal head with crowning. You'll be able to see the bulge and the fullness in the vagina from the placenta. When the placenta is delivered, the provider should inspect both the chorion and the amnion sides to make sure that there's no placental fragments, no tears, the placenta is intact. Because if we have placental fragments, retained fragments, you are going to have an increase for OB hemorrhage events. So here you can see the placenta begins to separate, and the contracted uterus aids in complete placental release, and the shape changes again from discoid to globular. In picture B, the placenta enters the lower uterine segment. In picture C, the placenta enters the vagina and the cord lengthens. And in D, you have expulsion of the placenta and the end of third stage. In looking at this placenta, what you're seeing is the chorion side. So this is the side that attaches to the uterine wall. We also refer to this as the dirty Duncan side. Can you look at this and can you actually see defined segments or lobes? remember from way back in the beginning when we were talking about development, the placenta has 15 to 20 lobes, and we call these cotyledons. If the placenta were to fragment and to break off, then it would leave pieces of the placenta, the cotyledons, behind, and the woman wouldn't be able to contract down on her uterus, so she would have uterine atony, and therefore the result would be a hemorrhage event. So having a baby is like undergoing a procedure, and like any other procedure, there's a recovery period. In OB, we call this the 4th stage, which covers the 1 to 2 hours immediately after birth. During this time, the woman is assessed frequently for signs and symptoms of complications such as hemorrhage, because hemorrhage is the number one thing we have to worry about after having a baby. She's going to have her vital signs checked every 15 minutes, along with a fundal assessment and a bleeding assessment. Her temperature will be checked at the onset of 4th stage and then again at the end, unless we're concerned to see a need to check it before that. If she has an epidural, safety is a big patient factor that we have to deal with. We don't want her to get up without our assistance for the first couple of times after the epidural's out. She may not be able to feel the need to void, so bladder assessment is needed to prevent bladder distension until the voiding sensations can be felt. If she received a deeper anesthesia than an epidural, then PACU, post-anesthesia care unit practices, are initiated and followed. In cesarean deliveries, they actually go to PACU recovery on the labor and delivery unit. The mom will probably want food and fluids pretty quickly. I mean, she's been NPO except for, ice or IV fluids. She hasn't had anything to eat. This is hard work, so she's going to want something. So we want to make sure that we get her taken care of. A lot of times they'll order like a finger tray, a sandwich tray, or something simple for her to eat. If she goes skin to skin, watch for her interactions with the baby. Observe for signs of attachment and acceptance. How are they doing with breastfeeding? If assistance is needed, then offer the assistance. Kind of be there, be present, and give instruction and assistance as needed. Alrighty, so this concludes the lecture for Chapter 12. If you have any questions about anything, I know we talked a lot about a lot of this stuff we talked about in last week, so if there's anything y'all want to go over specifically, then bring it to class on Monday.